Sir, we're good to go.
Yeah, good evening, everyone. So, welcome to the weekly webinar, which is organized by Yashoda Hospitals. So, in association with Society of Emergency Medicine and Bar. So, every week we are coming to with a different topic by the different faculty. So, which is enriching our students and enlightening the current topics in. So, this week we are coming with shock in trauma. The speaker is Dr. Ravi Sankar, who is graduated from Kondle Medical College and did his MD Emergency Medicine from Narayana Medical College. He is my student. So he is now Associate Professor. So he will be talking about shock in trauma. So as well we know, shock is, trauma is one of the leading cause of death. And as there are number of traumas which are increasing around the globe, and if you take the 2021 statistics, the number of traumas are more and the number of deaths are more. And Dr. Ravi will be enlightening us what is the shock in trauma. Over to you, Ravi.
Thank you, sir. Thank you for your kind introduction. So good evening all. So today's topic is shock in trauma. So as Sir said, so if you take any disease, trauma has high mortality at around 16.9% on mortality and morbidity of 10.39%. If you take the magnitude of the illness or the magnitude of the thing trauma in India, it is more than even the COVID-19 or any killing disease. So it is the need of the hour that we should have an idea about how to manage trauma in hospital, in pre-hospital setting as well. So in trauma, the unique thing is there is a trimodal death distribution. So there are 3 peaks in trauma death. The initial first peak occurs within the seconds and minutes of the injury. So usually in these cases, death usually arises from apnea due to severe traumatic brain injury or high spinal cord injury or any rupture of the internal organs that like heart or aorta or any large blood vessels. So usually these type of patients, they won't give any time for us to resuscitate. So important peak is second peak, which occurs in minutes to hours. These group of patients, if we can identify and if we can resuscitate the patient well, so these patients will give us a huge chance for survival. So these are the deaths that occur in this period are usually due to severe head injuries like any STH or extradural hematomas, pneumothorax like tension pneumothorax, any intra-abdominal injuries like rupture of the solid organs like spleen, liver, and pelvic fractures or multiple other injuries associated with significant blood loss, which leads to hemorrhagic shock or hypovolemic shock. So the golden hour of the trauma care, which is usually very useful in these group of the patients, it is characterized by the need for a rapid assessment and resuscitation, which is the fundamental principle of the trauma life support. So it emphasizes the need for the identification and management of these patients in initial 60 minutes. But this duration is not intended to represent a fixed time period of 60 minutes. Rather, it is a time window that is give us an opportunity as doctors and pre-hospital care personnel to have a positive impact on the morbidity and mortality associated with this traumatic injury. So third week, which occurs several days, 2 weeks after the initial injury. Most of the times it is because of the multi-organ involvement or long-term infection sepsis. The care provided during the initial 2 weeks, the preceding periods affect the outcomes of this stage. So our objectives of this talk today is what is shock and how to define shock and what are the causes of shock in trauma patients and how to initially manage the patient with hemorrhagic shock in ED. So blood replacement and compound transfusion in management of shock and special situations like elderly and pregnancy in trauma. So what is shock? Shock is nothing but a state of circulatory insufficiency that creates a imbalance between tissue oxygen supply and demand, which results in end organ dysfunction, which leads to multi-organ dysfunction and death. single etiology, like any type of any single etiology that may manifest as various clinical findings of the more than one shock type. So hemorrhagic shock that creates a state of impaired oxidative metabolism and hemostasis due to inadequate oxygen delivery to meet the metabolic demand of the tissue and hypoperfusion of the organ. And the shock also produces a global insult to the vascular endothelium that which itself activates the coagulation and inflammatory systems, which leads to trauma-induced coagulopathy. So hemorrhagic shock, that is the most common shock in trauma, leads to an impaired oxidative metabolism, which leads to aerobic to anaerobic metabolism, and it will cause coagulopathy. So, few points about the normal physiology of the shock. As we know, cardiac output marker is the product of heart rate and stroke volume. So, initial change in the patients with trauma or hemorrhagic shock is the increase in the heart rate, that is tachycardia. So, stroke volume, which invariably depends on the preload, myocardial contractility, and afterload. So, preload, it is your venous return. In case of hypovolemic shock, preload will get affected. Myocardial contractility, any myocardial heart trauma, blunt cardiac trauma, or commotion or any other cardiac injury which leads to impaired myocardial contractility, which compromises the stroke volume. Afterload, that is the pressure in the systemic arteries. So low output state in trauma. In early period of the trauma, patient is having hypotension and tachycardia, which shows the signs of clinical signs of hypovolemia. We call it as 8-full-8. Patient will have respiratory distress. Patient will show low end-tidal CO2. Patient will be cold and commie. Patient will be pallor and venous collapse. And patient may have extreme tachycardias or bradycardias, and obviously patient will be shocked, and his GCS may alter. Patient may land up in altered mental status because of cerebral hypoperfusion. So initial phases of shock, we have to see for any clinical signs of hypovolemia. If we don't identify and resuscitate the patient in this phase, patient will land up in profound hypotension with variable heart rate. That is low flow perfusion with no palpable peripheral pulses. Patient may have narrow complex, that is sinus tachycardia. Patient ETCO2 may be increased. Myocardial contractility may get decreased. Patient may show signs of poor respiratory effort. So if we don't intervene in this phase, patient may land up in shock. That is patient may have broad complex tachycardia. Patient BP may become not recordable. Eventually, patient may leads to asystole PEM, where there is no benefit of volume or flow support. So we have to go with ALS guidelines for resuscitation. So how to approach to shock in trauma? The first step is to recognize the presence of the shock. Second step is to identify the probable cause of the shock and initiate the treatment accordingly. So most common cause of trauma, as we discussed, is hemorrhage. Traumatic hypovolemic shock secondary to large surface burns and chemical burns and deep skin lesions is a possible entity. So if you see the causes of the shock in trauma, most of the time it is hemorrhagic. But in non-hemorrhagic causes, that is cardiac tamponade, tension pneumothorax leads to obstructive shock, neurogenic shock, and cardiogenic shock and septic shock. So what are the sources of potential blood loss in trauma? That is external bleeding, blood on the floor plus 4 more. It is in the chest, abdomen, and pelvis, and the extremities. Most important thing is retroperitoneum, which we usually miss in our day-to-day clinical practice. So how to recognize the shock? So profound circulatory shock is an evident by hemodynamic collapse, inadequate perfusion. Patient may show signs of inadequate perfusion, that is cold, clammy skin. Patient may have decreased urinary output. Patient may be altered. It is very simple to recognize. But like as I told, cool to touch, tachycardia, it's very unproven that otherwise patient is in profound circulatory shock. But our point is we have to identify the cryptic shock. That is when patient is having in the initial stages of the shock, we have to identify. How to identify? Instead of depending on the sole indicator or single indicator like systolic blood pressure, we can delay the recognition of the shock, because most adults having tachycardia and cutaneous vasoconstriction are the typical early physiological response to volume loss. then how to identify shock early? So for that thing, we will take the ratio between heart rate and systolic blood pressure. We call it as shock index. Rather than taking a systolic blood pressure as the sole component, we will take the ratio between heart rate and the systolic blood pressure as an indicator of identifying the occult shock. So if this ratio is more than 1, that is patient is having occult shock. There is one more ratio, that is delta shock index, that is ED shock index, difference between ED shock index and field shock index. If it is more than 0.1, this indicates the ongoing bleed or continue bleed, which may be external or internal. So greater than 0.1 of delta shock index is associated with increased mortality because of ongoing bleed. This needs for blood transfusion and ICU, length of stay, and requirement of surgeon in ED. So one more measurement is narrow pulse pressure. Rather than taking systolic blood pressure, if you take narrow pulse pressure, it suggests the significant blood loss and involvement of the compensatory mechanisms. So measuring of base excess and lactate. Serial measurements of base excess and lactate not only usually determine the presence, but it will also help in the prognostication, and it will guide us in the resuscitation of the patient with hemorrhagic shock. So what are the signs and symptoms of hemorrhagic shock by class? So we will divide the hemorrhagic shock into 4 classes: class 1, class 2, class 3, and class 4. Class 1, we have approximately blood loss of less than 15%. There is no other signs. Heart rate will be normal, blood pressure will be normal. So this is the phase where we have to identify the patients in shock. So class 2 is mild, which is 15 to 30% of blood loss. Patient may have tachycardia and may have decreased pulse pressure. Every other parameters may be normal or slightly elevated. So tachycardia and decreased pulse pressure is the indicators for guiding class 2 or mild hemorrhagic shock. In class 3 and class 4, all the parameters like heart rate, blood pressure, pulse pressure will be deranged, and urine output will also be decreased. Patient will, GCS will be low, patient will be altered, or patient may go into coma as well. So class 3 and class 4 requires blood products and massive transfusion protocols and surgical interventions. So how to identify a bleed in ED? E-fast is the one of the easiest bedside. We can repeat or reproduce as when needed. So even thoracic cavity and abdominal cavity, we can see where is the bleed, and we can also identify the tension, pneumothorax and hemoperitoneum. So this is the fluid that is between the Morrison's pouch between liver and the kidney, indicates the there is a blood collection or ongoing bleed in the abdominal cavity. So it is hemothorax, presence of the fluid in the pleural cavity, which is compressing the floating lung margin. So this is pneumothorax. Normally what we see is in E-fast is seashore sign. In case of pneumothorax, what we see is a barcode sign here, which indicates the air trapping in the pleural cavity, which needs immediate decompression. So apart from these E-fast, we have laboratory investigations, like baseline laboratory investigations at the ED arrival. And apart from that, we will have blood grouping typing. We should take for it. We should send the samples for coagulation profile for any coagulation abnormality. If we have a point of care TEG or ROTEM, we can use the things. Apart from that, we can send for ionized calcium and ABG. So how to manage the hemorrhagic shock? The basic management principle of hemorrhagic shock is stop the bleeding. So without closing the tap, whatever amount of fluid or water that we fill in the tank is a waste. So first of all, we have to stop the bleeding, then we have to resuscitate. Most of the times we have to go in side by side. So initially ABC stabilization, when patient airway is not patent, labored breathing, we have to secure the airway. Hemorrhage control with ongoing fluid resuscitation. Whenever early blood products are available, we have to immediately transfuse blood transfusions. That is a damage control resuscitation. Frequent neurological examinations and complete examination in exposure, because any external bleeding or any injury in the back, which should not tend to miss, gastric decompression and urinary catheterization for monitoring of the urine output. So initial fluid therapy will be 1 liter or 20 ml per kg bolus, but persistent infusion of large volumes of fluid in an attempt to achieve normal blood pressure is not at all a substitute for the definitive control of the bleeding. The first point is we have to stop the bleed, or we have to try to apply the direct pressure in external bleeding. Then we have to do our resuscitation. So control resuscitation. Control resuscitation is nothing but the balanced goal of organ perfusion and tissue oxygenation. But we have to avoid the rebleed. For that thing, we have to accept the lower than normal blood pressure. That is called balanced resuscitation or hypotensive resuscitation. Coming to colloids versus crystalloids, no role of colloids in trauma or any other resuscitation, because colloids increases the mortality on organ injury. So the response for the initial fluid bolus, we can differentiate we can classify the people into rapid responders, transient responders, minimal or no responders. Rapid responders, they will return normal, their vitals will become normal, which estimated blood loss will be minimal. That is group 1 people. There is no need for blood. Need for blood is very low. So for even for rapid responders also, there should be presence of the surgeon is mandatory in the ED. Transient responders, after the initial resuscitation, there is a transient improvement, but there is a recurrence of decreased blood pressure or hypotension and tachycardia. So moderate ongoing blood loss. So there may be need for blood loss moderate to high, and there is need for early presence of the surgeon in ED. Minimal or no response. Patient vital signs will become normal. Patient will be hypotensive. Tachycardia will be worsening. That indicates the severe blood loss. Immediate replacement of the blood is needed. So highly likely of operative intervention is needed. So how to measure the patient response to fluid therapy? Apart from these clinical indicators, we have to regularly monitor the urine output, repeated blood gas analysis for serum lactate and base excess levels, which is prognostic in case of trauma. So early blood transfusion. How much we have to transfuse? Patients who are the transient responders or non-responders require PRBs and plasma and platelets as an early part of their initial resuscitation phase. The main purpose is restore the oxygen carrying capacity of blood and intravascular volume. Whenever they are available, fully cross-matched RBCs are preferable over uncross-matched blood. If cross-matched blood is not available, we can use type 4 RBCs as patient in exsanguinating hemorrhage. So when plasma, if you want to transfuse plasma, AB plasma can be given when uncross-matched plasma is available. In case of childbearing age, it is better to go with an RH negative PRBCs. So unmatched type specific PRBCs is preferred over type 4 PRBCs as soon as they available. So while giving transfusion or massive transfusion, we have to prevent hypothermia. So we have to use both blood and fluid warmers in our early resuscitative period. So even in case of massive hemothorax, we can still consider the option of auto transfusion, where there is the lot of amount of blood is there in the sterile pleural cavity. So in case of massive transfusions, we can supplement the calcium based on ionized calcium levels. So what is massive transfusion protocol? Massive transfusion protocol is defined as more than 10 units of PRBC requirement within the initial 24 hours of the admission. Early component transfusions in a balanced ratio compared to excessive crystalloid administration may improve the patient survival. This approach has been termed as hemostatic or damage control resuscitation. Simultaneous efforts to control the bleeding and reduce the detrimental effects of coagulopathy, hypothermia, and acidosis, which is a deadly trait in these patients, are extremely important. So it is not mandatory, or not every trauma patient or patient in hemorrhagic shock needs MTP. So who needs MTP? For that thing, we have a score, that is ABC score, which have 4 components. The total score more than 2 indicates the activation of MTP. And persistent hemodynamic instability in spite of the adequate fluid and volume resuscitation is indicative of massive transfusion protocol. And active bleeding, which requires surgery and embolization, which needs some time to shift the patient to the radiology suite or OT, needs initiation of massive transfusion protocol. So this is the model massive transfusion protocol. Ideally, every hospital should have their own massive transfusion protocol depending upon the hospital policies for their trauma needs. So how much we have to give? What is the end point of the massive transfusion? So if bleeding is definitive control of bleeding, either by surgery or any radiological procedure, then we can stop our MTP. If the further resuscitation is futile, patient land up in PEA or asystole, there is prolonged resuscitation, there is no point in transfusing more blood. So what are the laboratory guides to end the MTP? Hemoglobin is more than 10 grams. Your PT and APTT is less. If platelet count is adequate, more than 1.5. If serum fibrinogen level is more than 180, these are the laboratory indicates which guides us to endpoints of massive transfusion protocol. So as we discussed, this is the lethal triad in trauma, that is hypothermia and coagulopathy and acidosis. So we have to transfuse, or we have to infuse warm saline or warm blood products, and acidosis we have to correct. So what is the cause for coagulopathy in trauma? Combined tissue hypoxia, loss of coagulation factors from the hemorrhage. So as there is a massive blood loss, along with blood, there is loss of coagulation factors and hemodilution that occurs from the early fluid resuscitation. That may also precipitate coagulopathy in trauma, which is further exacerbated by acidosis, as evidenced by the elevated base deficit. There is when severe injury or hemorrhage, there is a consumption of the coagulation factors. That is consumptive coagulopathy, which will further leads to early coagulopathy. So as we discussed, hypothermia that occurred during the course of ongoing hemorrhage, and because of resuscitation, it will further worsen the coagulopathy trauma. Point of care studies, if they are available, these are not widely available in our country. If they are available, thromboelastogram and rotational thromboelastometry are helpful in identifying and treating coagulopathy, as well as they will guide us for component transfusion, the whole blood transfusion in trauma resuscitation. So these are the TEC and ROTEM patterns. Depending on the pattern, we can transfuse the component transfusion. So role of tranexamic acid in hemorrhage. So tranexamic acid is a synthetic lysine analog which stabilizes the clot, that is, which inhibits the activation of plasminogen to plasmin. So it has a potential benefit of decreasing fibrinolysis in the bleeding patient, so that it will stabilize the clot and will further decrease the bleeding. For pre-hospital administration of the 1 gram within the 3 hours of injury on field, or follow-up dose of 1 gram given over the 8 hours in the ED or in ICU, according to CRASH 2 trial, which significantly decreases the bleeding risk and associated with significant mortality benefit. So in extremity injuries, limb versus life-threatening injury. So when there is a bleeding, whether if it is a life-threatening or not, we have to see. So sometimes limb injuries also may lead to massive hemorrhage because of any vascular injury. They may anytime can be converted as life-threatening injuries, especially in penetrating external trauma. So when a case of penetrating external trauma, we have to do thorough physical examination, and we have to look for any hard signs and soft signs. Hard signs are any dimness or absent distal pulses. There is visible or obvious arterial external bleeding. There is a large pulsatile hematoma or any audible bruit or palpable thrill, which indicates a pulsatile hematoma. Any distal ischemia. These are the hard signs. When hard signs are present, immediate vascular or surgery consultation is needed. Soft signs like any stable hematoma or injury anatomically related to nerve. There is unexplained hypotension, history of hemorrhage, proximity of injury to major vascular structures and complex fracture. We have to go for CT angiography. If CT angiography is positive, then we have to go for vascular surgeon consultation. If it is negative, simple observation is enough. There is no signs of vascular injury, no hard signs and no soft signs. We have to measure ankle brachial index. So ankle brachial index less than 0.9, we have to go for CT. If it is more than 0.9, observation is needed. So in case of extremity, peripheral trauma, we can use the tourniquets. Combat application tourniquet, which is the used in the pre-hospital setting. So this tourniquet, we cannot, the disadvantage with tourniquets is, first of all, availability in pre-hospital setup. Second thing is, we cannot keep the tourniquet for long, usually not more than 60 minutes. These prolonged usage of this tourniquet may lead to compartment syndromes, damage to any nerve or muscle or vascular injury. Even patient may land up with gangrene, may lead to exsanguinate pain and loss of the limb also. So we have to release the tourniquet in every 1 hour or 60 minutes. So this is a pneumatic tourniquet where pressurized air is used to restrict the blood flow. So limb occlusion pressure is measured depending on the systolic blood pressure. So if it is lower limb injury, 75 millimeters of Hg above the limb occlusion pressure. If it is an upper limb injury, 50 millimeters of Hg above the limb occlusion pressure is maintained. So this is the case. One of the cases we received in our ED recently. So patient having one assault where patient brachial artery got injured when they went to outside hospital first. So they got treated for resuscitated for 2 to 3 hours. Then they took the patient here. So at the time the patient reaches our ED, patient was in profound shock. Patient was cold, clammy, irritable. So continuous external hemorrhage from this artery. So we immediately ligated the artery. Surgeon has immediately ligated the artery, but patient landed up in cardiac arrest. Initial 2 to 3 cycles of CPR, we got ROIC. We have started massive transfusion protocol, and then we have shifted the patient to CTVS department for emergency operative intervention. Then, even though patient has lost his limb, but patient life has been saved. So when there is an bleeding, actively bleeding external or vascular injury, we have to take the call depending on whether it is a limb-threatening or life-threatening injuries. So when there is a truncal hemorrhage, non-compressible truncal hemorrhage, if it is an external hemorrhage, we can give external compression or we can ligate the vessel. If there is a non-compressible truncal hemorrhage, like hemorrhage in the peritoneum or abdominal cavity or hemorrhage in the thoracic cavity, how to assess? So these truncal hemorrhages are more common in military trauma or sometimes in road traffic accident in civilian trauma as well. So these are the two resuscitative measures, that is resuscitative thoracotomy and endovascular balloon occlusion of the aorta. So Ribova and resuscitative thoracotomy are the two new methods that are they are not widely used, but they are the ones useful in case of truncal hemorrhage for timely resuscitation. So for resuscitative thoracotomy, it is mostly for open cardiac massage and the aortic cross counting. This resuscitative thoracotomy needs CTVS surgery in ED. So resuscitative endovascular balloon occlusion of the aorta, it is a temporary cessation of the blood until the patient has been shifted to definitive surgical management to OT. So this is the Ribova catheter. So in Ribova catheter is a 7 French catheter. We will have 2 lumens and there is a occlusion balloon and a radiolucent tip. So if you see the zones of the aorta has been divided into 3 zones: zone 1, zone 2, and zone 3. Zone 1 is subclavian to origin of celiac trunk. Zone 2 is celiac trunk to the renal arteries. Zone 3 is below the renal arteries. So what are the indications of this Ribova? As we discussed, non-compressible exsanguinating torso hemorrhage or partial responders of the volume resuscitation, but we have to exclude the obstructive shock like cardiac tamponade and cardiac tamponade or tension pneumothorax. So severe, profound hypovolemic shock, not responding to initial resuscitation, and SPP less than 70 millimeters of Hg. Traumatic circulatory arrest is subdiaphragmatic hemorrhage, femoral vessel injury, evident subdiaphragmatic hemorrhage or femoral vessel injury, or any unstable pelvic fracture with hemorrhagic shock. So when patient is hypotensive, partial or non-responder, then we have to access the common femoral artery for Ribova. Chest X-ray, if there is a possibility of aortic injury, there is it is an absolute contraindication for initiating this reboa. If there is no possible aortic injury, so we have to take E-fast. If E-fast is positive, then we have to position the balloon and inflate the balloon in zone 1. Then we have to proceed for emergent laparotomy. If E-fast is negative, then we have to take a pelvic X-ray. Pelvic fracture is evident, then we have to position the ribova in zone 3 and we have to inflate. If pelvic X-ray is normal, then again we have to reposition ribova in zone 1. In ribova, zone 2 is non-inflatable zone. Only zone 1 and zone 3 are inflatable zones. So this is tip at the zone 1. This is tip at the zone 3, below the level of renal arteries. So what are the contraindications of ribova? So as we discussed, intrathoracic bleeding or any aortic or large vessel injury, PEA more than 10 minutes duration, elderly age group, cardiac arrest due to other causes than hemorrhagic shock, that is obstructive shock or neurogenic shock. Blunt thoracic aortic injuries is an absolute contraindication for initiation of ribova. Clinical or radiological suspicion of traumatic aortic dissection is also a contraindication for initiating the ribova. So when you compare ribova versus RT, the lower mortality group is with ribova. This is the study that has been conducted in limited number of patients, that is 11 patients, where they have compared between ribova and RT. So when compared to ribova versus no ribova group in hypovolemic shock or hemorrhagic shock, there is no significant difference. Health quality of life, there is no difference between ribova and resuscitative thoracotomy. Overall, ribova has low mortality rate compared to resuscitative thoracotomy. But the ribova versus no ribova group, there is no significant difference in the patient outcome. So further studies are needed in resuscitating these procedures, which are not widely performed or widely available in all centers in our country. So apart from hemorrhagic shock, there are causes of non-hemorrhagic shock in a trauma patient. Cardiogenic shock. Cardiogenic shock is myocardial dysfunction caused by a blunt cardiac injury leading to cardiac tamponade or any air embolus, rarely a myocardial infarction. So when to suspect a blunt cardiac injury? We have to suspect blunt cardiac injury, rapidly decelerating thoracic trauma patient, like our steer wheel injury. So continuous ECG monitoring and 2D echo is needed. So obstructive shock, cardiac tamponade and tension pneumothorax. Cardiac tamponade is more common in penetrating, but can also occur with blunt thoracic injury. Backstride, like muffled heart sounds and engorged neck wings and hypotension not responding to fluids is the classical findings that we see in case of cardiac tamponade. But it is not mandatory that every patient with cardiac tamponade show all 3 signs. E-fast at the bedside and 2D echo are the guide. Very immediate pericardiocentesis to relieve the obstruction around the heart is vital. Sorry for that. That video is, the clip is missing, so I'm not able to play the video in this PPT. So it is a tension pneumothorax where there is a massive air trap in the pleural space, shifting entire one mediastinum, pushing one mediastinum to opposite side, which further leads to hypovolemic or decreased venous return, leading to shock. That is obstructive shock. So post ICD, there is expansion of the lung and the obstruction is relieved. So yes, shock has been relieved. Neurogenic shock. Isolated head injury usually never causes a shock unless there is an involvement of the brainstem injury. So if there is acute brain or brainstem injury, sudden catecholamine surge, which acts on alpha and alpha beta receptors, which further leads to LV failure by increasing the LV afterload and direct myocyte injury through beta receptors. But because of platelet aggregation and there is pulmonary capillary injury, which may causes the neurogenic pulmonary edema in case of acute brain injury. So usually isolated injury never causes, but there is a brainstem injury. This may lead to neurogenic shock and cardiogenic shock. C-spine and upper thoracic spine injury can produce hypotension due to loss of the sympathetic tone. In these neurogenic shock, hypotension without tachycardia. Usually hypotension in trauma, either with a blood loss, either an obstructive, may associate with tachycardia. But in neurogenic shock, there is without tachycardia, even a patient may see bradycardia. So septic shock can occur in delayed presentations to ED, especially in elderly age group, secondary to fall. Most common infection is UTI or urosepsis. It is more common in penetrating abdominal injuries leading to abdominal sepsis, usually treated with fluid resuscitation and early vasopressors and antibiotic therapy. So how to monitor of the initial resuscitation? So after initial resuscitation, it is always we have to reassess the patient, reassess the organ perfusion, reassess the tissue organization. How to assess the organ perfusion? By monitoring the urine. How to assess tissue oxygenation? By measuring your serum lactate levels and base excess. And even your organ perfusion can be measured as improving CNS function and skin color. Return of heart rate and tachycardia should be normalized and BP towards the normal levels. So in coming to special situations, in advanced age, elderly trauma patients, they exhibit a poor result, a poor tolerance to hypertension secondary to blood loss, decreased sympathetic activity because there is a decreased receptor response to catecholamines, and cardiac compliance decreases with age, and atherosclerotic vaso-occlusive disease may precipitate shock. Previous usage of beta blockers blunt the response to hypertension, which leads to delayed identification of the shock and decreased pulmonary and renal compliance. So medications, any chronic usage of beta blockers and calcium channel blockers, they may blunt the physiological responses to hypertension. Diuretics may lead to hypokalemia. Insulin may lead to hypoglycemia, which may be cause for their fall and trauma. NSAIDs may increase the bleeding rate, further worsens the coagulopathy. So when elderly patients using any anticoagulation, if there is an active hemorrhage, we have to reversal the action of the drugs that they are using. If they are using antiplatelets, we have to transfuse the platelets before performing any surgical procedure. If patient is on warfarin, we have to supplement FFPs and prothrombin factors, prothrombin concentrate or factor 7 or vitamin K. If he is on hemodialysis patient or using heparin, we have to reversal the action of the heparin by by giving protamine sulfate. If patient is on direct thrombin inhibitors like dabigatran, we have to give reversal drug like idarucizumab. So in pregnancy is usually a hyperdynamic state. Normal hypervolemia that occurs with the pregnancy means that take amount of blood loss to manifest the perfusion abnormalities in the mother, which may be reflected in decreased fetal perfusion. In pregnancy, we have to resuscitate two persons. One is maternal resuscitation. Second thing is fetal resuscitation. In pregnancy patient, if there is a proper immobilization is needed, we have to keep a wedge behind the spine board, which allowed log roll of 4 to 6 inches to displace the gravid uterus to the left, so that venous, that is compression over the inferior vena cava can get relieved, and the placental perfusion and fetal perfusion will be not be compromised. So in pregnancy, there is a high chances for concealed hemorrhage like abruptio placenta. Even a trivial trauma to the gravid uterus may cause abruptio placenta. So we have to always keep in mind that concealed hemorrhage is more common in pregnancy patients. So what is it? How we will proceed for decision making in emergency obstetric care in ED in case of trauma in pregnancy? So in primary fetal survey, if uterus is more than 22 to 24 weeks, then we have to see how is the fetal heart. Fetal heart tone is stable, then we can monitor for 4th hourly. If fetal heart rate is unstable, if it is more than 22 weeks of gestation, then we have to go for emergency C-section. If uterus size is not more than less than 20 weeks or 22 weeks, then we have to focus on maternal resuscitation. So in primary maternal survey, if mother is stable, then wait and watch. Then you have to go for secondary maternal survey and fetal heart rate. If monitoring, then stable or unstable. If mother is unstable, then we have to do maternal resuscitation. If maternal resuscitation is stable, then we have to go for secondary maternal survey and fetal assessment. So, traumatic cardiac arrest algorithm. When a penetrating or blunt trauma patient presents to ER with no pulse and PEA, how to approach? So it's a operating room with surgeon present is a mandatory for traumatic cardiac arrest resuscitation. So traumatic team should be alerted by a medical dispatch or pre-hospital team. When closed CPR in progress, and we have to take care of the CPR, and we have to secure an airway and external cardiac massage like chest compressions, and we have to secure airway by orotracheal intubation, and we have to provide 100% oxygen, adequate IV lines, and fluid resuscitation. So if ROSC is there, then we can proceed with usual resuscitation, trauma resuscitation. If ROSC is not there, we have to bilateral chest decompression. If bilateral chest decompression, if we get ROSC, then we have to give chest tubes and we have to proceed for usual resuscitation. Even after bilateral chest decompression, there is no ROSC, then we have to proceed for a clamshell thoracotomy. That is, it should be less than 3 minutes. Presence of a surgeon or CTV surgeon is mandatory for this clamshell thoracotomy. If there is a direct cardiac injury, then we have to try to control the cardiac lesion. If there is a laceration over the heart, try to repair the heart wound. There is severe hypovolemia, then we have to examine the thorax and pulmonary pedicles. Mediastinal vessel should be clamped. If there is an EFAST in abdomen, then we have to clamp the descending thoracic aorta, and we have to continue the resuscitation. If patient further succumbs into cardiac arrest, then we can go for internal cardiac massage and internal electric shock by internal defibrillator, as already we have performed thoracotomy. If there is no ROSC attained after 30 minutes of the trauma resuscitation, then we have to declare the patient as dead. So coming to an key concepts of trauma resuscitation is, first step is management of shock patients to recognize its presence. Recognizing shock is very vital, especially in early phase. Single shock trauma etiology may manifest in the clinical findings of more than one shock type. Definitive control of hemorrhage is vital, and restoration of adequate circulatory volumes are the main goals for treating hemorrhagic shock. Until unless you stop the hemorrhage, whatever the blood or fluid you are giving is waste. Judicious use of blood products and early usage of blood products and early initiation of the MTP on case-to-case basis is recommended. Isolated head injury usually never causes hypotension except there is a brainstem injury. If you receive a patient with traumatic brain injury in shock, always look for other causes. So apart from doing our part, it is our responsibility to encourage the good Samaritans which allows the transport of the trauma victim early to the ED or any medical hospital. So awareness programs or education programs and community based on simple tourniquet application and simple pressure application are recommended. So training of the healthcare physicians in doctors for ATLS and for staff, state or district training programs are need of the hour. So these are my references. Thank you.
That is an excellent talk, Ravi, covering from the basics. Like you have given the etiology, physiology, the investigation part, then the resuscitating thing, and the treatment part. And
Thank you, sir.
any questions, you can raise your hand or. So as we all know, for the any research station or the any arrest, so we have the first 10 minutes, the platinum 10 minutes, and the first 1 hour, the golden hour, which are important for a research station and the outcomes. So the goals of any trauma research station will be, again, there are 4 things. One is minimizing the hydrogenic injury, then controlling the bleeding, which can be a ribova, it can be putting a chest tube or putting a tourniquet. Then promote the hemostasis. It can be a drugs like the Trenexa, the cryo, or the doing the tech. And lastly, the restoring the perfusion with the blood. So the main goal will be doing a damage control resisting, that is your maintaining the permissive hypotension. So maintaining a BP of 90 systolic or and in a head injury, maintaining a map of more than what we regularly maintain. That is, normally we maintain a map of more than 65. So maintaining a map of nearly 75 to recently they say maintaining a map of nearly 90, in especially only in the head injuries. So again, the role of crystalloids, it is, so again they say is again minimize the fluids rather than dumping it, like starting from 250 cc to 1 liter, and give blood as early as possible. And the role of vasopressors in trauma is still a controversy. So still they are not able to give a conclusion. Any questions from the attendees? So if there's no questions, we will wind up the session. Thank you, Ravi, for the excellent talk. So,
Sir, thank you, sir. Thank you for the opportunity. And I thank Yashoda Hospital Emergency Department Group for providing this opportunity to share our experience and knowledge. Thank you, Raghu, sir.
thank you, Ravi. And thank you, Yashoda Hospitals. Thank you, Semi Board. Thank you, Dr. Srinath, sir, for arranging this webinar weekly and which is helping the students by enlightening the knowledge from the different speakers from different faculties around the centers. Thank you. So if there are no calls, we will wind it up. Okay, thank you, Ravi. Bye.
Sir, bye, sir. Thank you, sir.